This lecture, but I will try and tie in what we talked about in the morning to real life stuff related to OT. So again, trying to think about the cerebellum as a whole, we talked in the morning about the functions of the cerebellum. So we talked about it smoothing out movement, helping the cortex be more coordinated and synergistic in its movements, contributing to posture and balance and all of that kind of stuff through the connections with vestibular nuclei, through connections with reticular formation. So keep normal function in the back of your mind, because we're going to start out with a bunch of terms that relate to dysfunction of the cerebellum. And then what that will kind of midway through talk about what those symptoms, how they often co-occur together, and what that would look like in different types of disorders. So the first sort of thing to remember when we talk about cerebellar lesions is that when there is damage to the cerebellum, we're not getting paralysis, or we're not getting loss of sensation. Those were things that we saw when we had injury to the cerebral cortex, or when we had damage directly to the spinal cord, potentially even to the brainstem. But when we have lesions or loss in the cerebellum, we're going to see a loss in the quality or the smoothness of movement, which is sort of similar to what we saw with basal ganglia, right? If we damage the basal ganglia, we're not really getting paralysis, we're getting a loss in quality of movement. But the manifestation of that is going to be different than what we saw last week with the basal ganglia. So one of the first terms, and again, this is pretty well outlined in your book, that you should be familiar with is dysmetria. So dysmetria is the inability to estimate the range of motion necessary to reach for a target, and it manifests as either overshooting or undershooting a target. And this is the classic test, is you ask somebody to put their finger on their nose and with their eyes open move their finger to a target, usually your finger or maybe a pen or something that's about an arm's length away from them. And you can look at the quality of the movement with and without eyes closed. But typically if there's a cerebellar lesion, you're going to see this dysmetria, this over or undershooting, even when their eyes are open. So real quick, turn to the person that's next to you, have them hold out their finger, somebody hold out their finger as a target. You do it. This way I know if you've been drinking before class. Cerebellum has to do Okay. Yeah, Leah.
Is this part of the
Yes, it is. Quick neurological screening test. Yeah, and which you will do next semester in the fall in PEDS. And I think I have it on another slide because several of these tests are part of the quick neurological screening test. And reflect cerebellar function.
If you do it with your eyes open, how do you know that it's not a problem with depth perception?
That's a good question. If you do it with your eyes open, how do you know if it's not a problem with depth perception? I think you will have to tease that out if you think there's a potential problem with depth perception, because that is something you could see. If you ask them to, you can test depth perception on its own and see if that's a contributing factor. If you have a cerebellar lesion, dysmetria is going to be part of a conglomeration of symptoms. So if you have this dysmetria in addition to synergia, geez, I can't even say that, it's the next one, or synergy of movements, and hypotonia and intention tremor, then you're going to say, okay, all of those things together tell me this is a cerebellar lesion, not depth perception problem. So you're going to look at the whole picture here. We're just kind of looking at them in parts. Okay, so dyssynergia, there we go, better if I read it, is our next term, and this refers to when you cannot smoothly coordinate joint movements at the same time. So in dyssynergia, you have movement of the joints are separate instead of simultaneous. So when I talked about learning tennis earlier, and having to break down all those different movement parts before I hit the ball. You know, you plant your feet, then you bring your arm back, and then you swing it through. You know, eventually you're able to do all of those things simultaneously and without thinking about them. They become very automatic. What happens with cerebellar lesions is that you can lose that automaticity of movement and you revert back to having to do things in isolation of parts. It's sometimes referred to as decomposition of movement, and the movements appear jerky or broken up. And we typically think about it as our body movements, or as OTs, we're thinking about it in terms of reaching or mobility, but it can affect speech as well, where speech does not come out fluid, and words themselves, particularly words with multiple syllables, each syllable is having to be enunciated separately instead of being able to put that word together and say it in a smooth and coordinated manner. And I should say, we're going to go through about 6 different symptoms or conditions, and then we're going to look at a video that shows the screening for all of these. So you'll get to see what this looks like. The next term you should know is, I think we've talked about diadochokinesis before, but dysdiadochokinesis or adiadochokinesis refers to a difficulty or an inability to perform rapid alternating forearm movements. And so what that would look like is typically you'd have somebody sitting and resting their hands on their thighs and ask them to do this. So simultaneously pronating and supinating their arms at the same time. And what you're going to look for is the smoothness of the movement so that they're not having to stop and turn. You're going to look at the coordination, the ability to move both hands at the same time, and whether or not there's any shakiness or tremor while they're doing it. So go ahead and observe your partner, see how quickly they can do it. Okay. That looks better. That's better than your finger to nose, I think. So as Leah mentioned, this is part of what's called the QNST3, which is the Quick Neurological Screening Test 3rd edition, which I have listed under kids, but that actually goes all the way up to adults. And another test that you'll learn to give next semester, which is the Clinical Observation of Motor Performance Skills, COMPS. Is that what it stands for, Carol? Something like that. And for kids, sorry, you're just observing. I shouldn't ask you to think. There are norms available for kids. So for young kids, we're really only looking for about 2 to 4 full patterns in about a 10-second time period. This skill matures as the cerebellum matures around 7 to 8 years of age. And on average, you'd see at least 10 rotations in a 10-second time period. As you guys did it, you probably got a lot more. You know, for the QNST3, there are going to be norms for adults, but a lot of times, if you're just doing this as part of a quick screening, one of the things you can do is if there is an affected and a non-affected side, you can really compare the non-affected side, the smoothness, the quality, the number of rotations, to the affected side. If both sides are affected and you have damage in both hemispheres of the cerebellum, then you can just look at the quality of the overall movement. Again, looking for jerkiness, shakiness, tremors, discoordination between those two sides, because those would all be observable in somebody that had cerebellar damage. Yeah, Tatiana.
What's another example of rapid alternating movement besides the pronation supination?
It is the most common one. I think you could probably look at something like, this would be hip external rotation, but you could look at something like that, like a foot movement. Typically, it's going to be tested with the forearms. Another thing you might see with cerebellar lesions is nystagmus. And so it's not going to be, when we looked at nystagmus related to vestibular system, and we talked about it mainly with kids, we talked about doing the full rotary and post-rotary nystagmus and what that would look like. When we're talking about cerebellar nystagmus, typically you can elicit a nystagmus just by asking them to track an object, and when their eyes hit that end range, you see a snapping back of the eyes. It's sort of involuntary, automatic. So it's a jerkiness in the eyes. during smooth tracking. And we think that this is because of that connection that we saw this morning of the cerebellum with the vestibular nuclei. So lesions to the vermal region, what part of the vermis do we think is going to be associated with vestibular functioning? Good try. The vermis is that part in the middle. So what part of that vermis is going to be receiving vestibular information? What lobe of the brain receives vestibular information? Whoa. It's not anterior, it's not posterior. What's the other lobe? Flocculonodular lobe. So what part of flocculonodular lobe is part of the vermis? The nodule. So lesions probably to the nodule region of the vermis, or the fastigial nucleus, which was that deep cerebellar nucleus that vestibular information projected to. Lesions to either of those can result in cerebellar nystagmus, and again, it's probably disrupting that output from the cerebellum either to the vestibular nuclei, which is going to travel through the MLF to, this is from a couple weeks ago, through the MLF to the extraocular motor neurons located in the cell bodies of cranial nerves 3, 4, and 6. Okay? Ring a bell? Okay, Scott.
Would you expect someone that's in that level with like spun, or would it be easily, or would it just be like
I don't know how they would respond to being spun. I've never spun somebody with an outright cerebellar lesion.
Is the cerebellar nystagmus different than like a resting nystagmus, or are all resting nystagmuses cerebellar?
You're not allowed to ask.
Because like
Sarah-
people with the nystagmus.
I assume you could have a resting nystagmus with a cerebellar lesion. I don't know that all nystagmuses are cerebellar related. You can have damage to the vestibular nuclei in the brainstem themselves. In terms of Sarah's question, I don't know about spinning. I would assume that you would have greater nystagmus instead of diminished nystagmus because you're getting the wrong input, and so you're seeing more nystagmus even with simple movements like visual tracking.
Wait, so abnormally, what's going on here? You're just seeing their eyes shake as they track an object?
You're going to see it in the video. So
Okay.
as they're tracking, when they hit end range, instead of being able to hold that end range or be able to, keep their eyes here and then smoothly track back, when they
Yeah.
hit end range, you're going to see fast phase nystagmus, usually just back to the center.
So you're seeing nystagmus when you normally wouldn't see it?
Correct.
Okay.
Right. So if I'm asking you to track, you should be able to smoothly track to your periphery and smoothly track back out. And what's happening typically is that when you smoothly track to the periphery, which they can do, they're having an automatic nystagmus back to the center. It's very quick, very jerky,
Okay.
instead of being able to slow phase track back. So it's a nystagmus when you would not expect to see a nystagmus. Yeah, Heather.
What do you think? I actually saw this kind of good work. I think, well, something similar to this presented similarly at the school. And I kind of saw that because I just had the child just track this, did like a very formal mentoring. And yeah, it looks like exactly happened. Or just lose it and just snap back.
Okay, yeah, so good example. So yeah, this doesn't, you'll see in the video that it doesn't take any fancy equipment. It's just sort of that normal tracking that you see the jerkiness and the losing the smooth pursuits in the middle of, usually near the end range. You see that snapping back when you would not expect to see it. All right, couple more. Hypotonia is sometimes seen with cerebellar disorders. Again, we've talked about hypotonia before, low muscle tone. One of the things that you may see is an atypical an atypical response to reflexes. So not diminished reflex, not hyporeflexia, but sometimes after a stretch reflex. So if you hit the knee joint, the knee would normally jerk out and then return to rest. What you might see is that the knee just keeps flopping. It just keeps going. And you could do that with any of the reflexes you talked about. So you could stimulate the biceps. but you see this sort of residual floppiness, residual activity in the muscle. So it's not well understood why we have hypotonia in cerebellar disorders. There's some questions, some research that suggests it could be due to damage to the vermal, again, that central part, or paravermal, the area surrounding that region. It also might be due, and this is right out of your book, to loss of excitation to those vestibular nuclei, because we know vestibular spinal tract information is traveling from the vestibular nuclei and helping to excite the extensors in the spinal cord. So maybe that relationship to gravity, or ability to come up and extend against gravity, is somehow impaired. So again, we don't quite know, you don't need to know, but know that hypotonia is something that you may see in people that present with cerebellar lesions. All right, last one is called rebound phenomenon, which is the inability, and sometimes it's called rebound phenomenon of Holmes, Holmes. I think your Pedretti text calls it by its full name. But it's an inability to stop a motion quickly in order to avoid striking something. And usually when you test this, can I get you to come up here, Paige? Do you mind? You would ask them, just like in the picture, to do like, this would be like during manual muscle testing, right? And so I'd say, I'm gonna push this way, resist my movement. So she's pulling towards herself, right? And if I let go, she's able to keep her arm there. In rebound phenomenon, I'd be, resist me, I'd be pulling, and when I let go, she wouldn't be able to stop that motion, and her tendency would be to come up and usually hit herself in the face, which I wouldn't have let you do. So you'll see in the video how if you are doing testing, manual muscle testing, or testing this reflex, it's not a reflex, sorry, testing this phenomenon in somebody that you think has a cerebellar lesion, if you're doing manual muscle testing, you should protect them, and the video will show you how to do that so that they don't end up whacking themselves in the face, or whacking you, depending on which way you're facilitating the movement. They go through proper sanitation procedures just in case you weren't sure how those machines work.
We're now going to demonstrate the cerebellar exam. The cerebellum can be affected in many of your patients, and you might not recognize that it's affected unless you test the cerebellum. The signs of cerebellar dysfunction from head to foot are scanning speech. So if you ask the patient to say something with many consonants in it, such as the British Constitution, they might say the British Constitution. Scanning speech, breaking it out into individual syllables. They might have nystagmus. So if I ask the patient to follow my finger, they would have a nystagmus with the fast phase pointing to the site of disease. I should also say that if they have disease in the vermis and flocculonodular lobe, the patient wouldn't even be able to sit up. They would have truncal ataxia, and you would not even be able to get this far in it.
You'll see the nystagmus in the next video. I thought he was going to show it in this. This guy doesn't have any real issues. He's a pretend person. But you'll see it when I show you the kid with the toxic CP. Sorry about that.
Testing. Continuing after doing scanning speech, nystagmus, we would now look for dysmetria with the finger-to-nose test. The whole idea here is to try and put as many joints in play as we can. Just count them. 1, 2, 3, 4, 5, 6. As many joints as we can. So they're working together. And the great beauty of the cerebellum is that it's able to coordinate all of this in one smooth motion. And I'm going to now ask the patient to touch his nose as quickly as he can. Back and forth if you don't mind. Excellent. And now touch my finger in your nose. This task, which is not easy, comes about because of the impact cerebellum. Another test that you can do is called the rebound test. It's called the rebound phenomenon or test of Stewart and Holmes. When I ask the patient to pull on my hand if you would, when I let go, if I were to let go suddenly, the hand doesn't go and hit him in the face because the antagonist muscle quickly stops the movement. But in cerebellar disease, that may not happen. So protect the patient by putting a hand across the chest. Pull on my hand, please. One more time. And again, if the patient had cerebellar disease, the hand might go flying up there, and that is why you need to protect them. I'm now going to test for rapid alternating movements. So if you can put one hand out like so, and with your other hand, do this as quickly as you can. Do it and this phenomenon, if it's abnormal, is called dysdiadodocokinesia. The next thing we look for is pendular knee jerks. Patients with cerebellar disease might have hypotonia, but it may not be very evident because we're much more tuned to looking for hypertonia than hypotonia. And one manifestation is that when you do the knee reflex, in a patient with cerebellar disease and hypotonia, the leg will keep swinging 3 or 4 or 5 times after you've done the reflex as an indication of their hypotonia. We're now going to step into the hall and do the gait. The cerebellar gait is characterized by a broad stand and by a wide staggering quality to it. People will tend to fall towards the side of their illness, so if the illness is in the cerebellar hemisphere on the left, they might fall in that direction. When asked to stand still, their trunk may sway like this, and that is called titubation. And obviously they would have problems with all the other cerebellar tests. One caveat, many people think of the Romberg test as being a test of cerebellar disease. The Romberg test has nothing to do with the cerebellum. The cerebellar patient is already swaying, and it gets a lot worse when you have them close their eyes. But the Romberg test is really a test of proprioception. When you and I are standing like this with our eyes open, we are getting signals from our joints to tell us where we are in space. If, however, you have a problem with proprioception because of your peripheral nerves or posterior columns, then you're relying on your eyes to tell you where you are in space, and therefore, the moment you ask the patient to stand still and close their eyes, the patient begins to sway. And that is a positive Romberg test. It has very little to do with the cerebellum.
Okay, so, alright, did you guys have you done Romberg tests with Al in your dump class? Okay. I don't know, all he's saying is that because if you're trying to look for cerebellar lesions, you don't need to have them do this or do any of these tests with their eyes closed. They can have eyes open, they can be using vision as you're doing these tests. Now, if you're trying to get really at, is there a deficit in proprioceptive functioning? We talked about this when we did somatosensory system. You're going to be doing most of these tasks. You're looking at their quality of movement with their eyes closed. So trying to distinguish, are they relying heavily on their vision to move their body, or are they aware of where their body is in space? So that was the distinction he was trying to make. So postural sway, you would see in somebody with a cerebellar lesion, this type of movement, even if their eyes are open. Okay, and again, we'll take a look at all of those things again in somebody who truly has those disorders, and it might make a little more sense. I just want to throw out this term ataxia because it is a term that you will hear and you may have heard already in some of your classes. It is a lack of voluntary control of mother. That's supposed to be motor. That was not correct there. You might have a very coordinated mother, but this is motor coordination. Sorry. Ataxia is not always caused by a cerebellar lesion, and I think that's where it gets a little bit confusing, because you can see jerkiness of movement in some of these problems if there are lesions to thinking about the places that the vestibular system projects to. If there's a problem in the vestibular nuclei, you may see some issues with balance or problems with gait. If there's lesions in the dorsospinocerebellar tract that we talked about today, those tracts that are projecting up and feeding into the cerebellum, you may see, again, some problems with gait or some problems with proprioceptive input, with coordination of movement. So ataxia can be due to things other than cerebellar lesions. It is usually attributed to cerebellar lesions, which is why we're going to talk about it related to the cerebellum. Ataxia is not one specific thing. It is usually a constellation of symptoms of things that we've just talked about. Dysmetria, asynergia or dyssynergia, dysdiadochokinesis, postural instability. Gait ataxia he talked about in the video. So a wide base looks very staggering, and he talked about that if this is due to a cerebellar lesion, that the person will tend to stagger or fall to the side of the lesion. So if the stagger is always to the right, like this, then it's more likely the lesion is going to be on the right. And the other piece that we sometimes see in ataxia is an intention tremor, which is as the person starts to move or begins voluntary movement, then we see the jerkiness and the shakiness start. How does that differ from the tremor that we saw with basal ganglia? What type of tremor do we see with the basal ganglia disorder? Resting tremor. So that's important to distinguish. When is the tremor happening? Is it happening at rest? That's going to tell you basal ganglia. Is it happening during movement or at the start of a new movement, voluntary movement? Then you're thinking cerebellar disorder. And again, just to try and tie it into the morning, and to lab, when we talked about the different lobes, depending on where the lesion or the dysfunction is, we may see different presentations of ataxia or a different grouping of those symptoms that we've talked about. So damage just to the vestibular cerebellum or to the flocculonodular lobe is going to affect those things that are most contributed to by the vestibular system. So postural stability is a big function of the vestibular system. If we lose that, and we lose that connection with the cerebellum, we could have postural instability. The ability to control our eye movements through those connections with the cranial nerve motor nuclei. We can lose that, impairing our voluntary control of eye movements. If the dysfunction is in the spinocerebellum, which is mainly that anterior lobe, but can be parts of the posterior lobe as well, damage to the spinocerebellum is going to result more in that ataxic gait, again, falling towards the side of the lesion, and potentially hypotonia. Because again, that's information that's coming in from the spinal cord, all that proprioceptive information about where our muscles and joints are. If we lose that, or we lose the cerebellum's ability to use that information, we lose that smooth, coordinated movements in the body, we lose, particularly related to our lower extremities through that dorsal spinocerebellar tract, the DSCT that you looked at today. And then lastly, damage in those lateral hemispheres, again, anterior and posterior lobes. That's the part that's carrying out that voluntary movement. It's that reciprocal circuitry with the cortex that we're losing. So the ability of the cerebellum to both receive and then send output to, particularly M1, or the primary motor cortex. And damage there is going to result in initiation tremors, dysmetria, dysdiadochokinesis, rebound phenomenon, and probably dysarthria, which is, have you guys heard that term before in your other classes, which is sort of that disconnected or slurred speech. So one of the disorders you may have already seen in either med lectures or your PEDS class is ataxic cerebral palsy. This is one of the least common forms of CP. I think it is the least common form. About 10% of CP cases are considered pure ataxic cerebral palsy. And it's defined by symptoms of jerky movement, or unsteady or imprecise movements, tremor during movement, again, not a resting tremor, tremor during movement, problems with balance, often problems with speech and swallowing. So again, think about the cerebellar projections to the motor cortex. Motor cortex doesn't just project to the neck down. Corticobulbar tracts are going to project to muscles of the face, muscles used for mastication, for chewing and swallowing, so that can be disrupted as well. And they may also have hypotonia. So this is the video I'm going to show you.
Jeez, is that right, Nathan?
Okay, so this is Nathan, and I believe he says he's 6 right now, but we're going to take a look at him at 6 and 9. I don't think they go any older than 9. So take a look at the video and see if you can pick out some of the things that we just talked about. They're going to do some of the specific tests, but look at his knees right now. What's going on here? I just heard mumbles. Okay, hyperextension of the joint. So what's that telling you about muscle tone? Low. All right, so he already looks low tone. I mean, you just look at the kid, and he looks, I mean, right here. All right, so let's take a look at him.
Right, mate. So just see how you go trying to stand by yourself.
Postural sway, okay, even with eyes open.
He's pulling his hands.
Sorry, go ahead, Ben.
I was saying he's pulling his hands in too.
Okay, so he's probably actually trying to fix a little bit, trying to gain some stability.
Do you want to do a bit of walking with Daddy holding on?
Sorry.
Step over forwards down.
Go and have a try. Get your balance. Take a couple of steps.
Maybe Dad just holds your hands and just take a couple of steps this way. Okay.
Here, you're safe.
Why do you think it was hard for him to take a step by himself? Maybe hard to initiate movement. Remember, that's usually a basal ganglia issue, though. So, well, potentially, because you could have a tremor on initiation, but just in the way he was standing. What do you think? Sorry, Terry, your hands up?
Well, I think motorizing might be hard for him to shift this way, but also because he's probably used to fall.
So there could be some fear of falling, but if you think about him, here, he's already got this wide base of support, but just because of the instability, it looked like he was having a hard time shifting his weight over to be able to release this leg. And again, think about problems with the cerebellum, just motor placement can be hard. So you may not have the plan yet to figure out, how do I shift my weight without losing my balance to be able to take a step? Try it again.
Take a couple of steps.
Maybe Dad just holds your hands and just take a couple of steps this way. Okay.
Here, you're safe. Go.
Okay, off you come. Walk this way. Okay, turn around, walk back.
So it's hard to see with his hand being held, but just the wide base, sort of a staggering gait, poorly controlled, not smooth, kind of characteristic.
Okay,
of
right
what
to
you'd
the
expect
wall.
to see.
Right to the wall, back up.
Okay. Yeah, right to, and then just come this way again. Come forward this way again. Good boy. Now turn around.
I'm gonna fast forward this just a few seconds.
Hey, Stacy, when he went from the standing still and he was able to break out of that, when his dad held his hand out and he looked at it, is that what, like the head shift, is that what made his weight shift? Because it looked like as soon as his head turned, he was able to move. Granted, he was kind of falling, but.
I might need to watch it, and it could be reflexive, just as his head turns, his whole body is going that way, just in terms of, I mean, kind of like we see like in log rolls with kids. I think it was more of, okay, I know I can catch something if I'm going that way. It looked like he was like, all right, I know I can do that.
Okay.
So it could have been either. I think they're going to go into eye
Excellent.
movements.
Off you go, mate. Off you go. Turn it off now. Put it back on. Good, very good. Okay. Okay, just put it in there.
You can see that jerkiness in the movement,
It's a hard one.
difficulty to
Very
accuracy.
good. Okay. Okay, mate, put it in there. Very good. Excellent. Okay, righto. So look, watch the pen
Look up. Don't move your head.
there. Good. Now look over to the left.
Keep looking.
Okay, look over to the right. Okay, good. What you do, mate? Look very carefully at the pen. Okay, look, watch the pen.
Penny.
You watch it? Watch it move. Okay.
So you saw a little bit of it right there, just as his eyes are hitting that end range, just that jumpiness, not being able to follow it, or when he tries to correct his over
Okay.
jumpiness.
Watch it come back.
Watch the pen.
Watch it go back again. Don't blink. Just watch it. You watching it?
Look at the pen, Ethan.
It's just a bit higher there. See? Okay, yeah, off we go. Good boy. You watching it?
Look at the pen.
Okay, come back the other way. Back you come. Looking at it? Look at the pen, mate. Okay, righto, walk down. Okay, so we'll forget about the pen. Okay, now give us a big smile.
Hold on. Alright, so this is Nathan at 9.
No.
Right. So can you say he had hit her hard
He had hit her hard
and had hurt her hand?
and had hurt her hand.
British Constitution.
Pretty constitution.
Around the rugged rocks,
Around the rocky rocks.
a ragged rascal ran.
A rocky rascal ran.
Very good. Okay, so just do that one with the hand. Close your eyes. Okay, now do your other one. Good. Okay. Okay, off you go. So keep going. Yeah, so right on the tip, and then right on the tip again. Okay, off you go.
You do that for a long time.
Okay, now look to your right quickly. Okay, look here. Look towards the camera. Now look to your right quickly. Okay, look up here. Look to your left. Right. Now just slowly look to your right. Now slowly look to your left. Right. Okay. Good on you, mate. Ready, set, go. Okay, now come out this way. Good work, okay. Good. So just do those few steps things. A few steps along. Okay, yeah.
I'm gonna back that up for a second. So when you watch his gait, again, it's that wide base of support, kind of staggering, not smooth, and he's having to still hold his hands up like this for the most part when he's walking, so close to his body, kind of flexed. So still trying to get that stability, so you don't see like a natural smooth arm swing. Okay?
So just do those few steps things. A few steps along. Okay, yeah. Good, keep coming. Alright, so just...
There, hallway walk.
Okay, now come out this way. Good work, okay. Good. So just do those few steps things. A few steps along. Okay, yeah. Good, keep coming. Alright, so just do that as one. Oh, you're right. You're right. Just do it one more time as a sort of a square. Good, 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 good. Good work.
Is this classified as a cerebral palsy because there are also problems within the cerebral cortex?
As far as I know, cerebral palsy is sort of a garbage diagnosis for any type of brain damage that happens at or around birth. So I don't think the term cerebral means that it has to be a pure cerebral disorder. Do you have anything to add to that, Carol?
I think that would be my.
Okay. Yeah. Okay, so last piece. I believe this is for Jamie, who was asking about alcohol earlier in the semester.
Meg Wright sent me a really good article that is directly effective to your semicircular canals after class.
Oh, so it can directly affect.
Well, she said it was a good question, and she sent me
So alcohol can have an effect directly on the vestibular system, which is when that question came up. Is more commonly thought to have, particularly its long-term, for chronic alcoholism, long-term degenerating effects on the cerebellum. So typically alcohol and the cerebellum are talked about in relation to each other. And as I'm sure you know, alcohol is a depressant, so it depresses the activity of the cerebellum through our primary inhibitory neurotransmitter, which we talked about last week, which is GABA. So it acts not only to increase GABA output in the cerebellum, but it also decreases the influence of glutamate in the cerebellum as well, which again we talked about last week, glutamate being the primary excitatory neurotransmitter in the basal ganglia, so that their functions don't change in the cerebellum. And I said that GABA and glutamate are all over the brain. Their roles are almost always the same, GABA being inhibitory, glutamate being excitatory. So alcohol has an inhibitory effect on the cerebellum, and when you're drinking alcohol and your body can't metabolize it fast enough, its short-term effects are related to loss of coordinated movements, again, because of inhibitory effects of this neurotransmitter, of GABA. So we see loss of coordinated movements, impaired balance, and often an ataxic or a staggering gait. Long term, we can actually have destruction of the cerebellum. So we can see degeneration of cerebellar neurons. And so this is a brain scan. Again, this is a mid-sagittal sort of section. So you can see corpus callosum. Would be like the arbor vitae of the cerebellum. But typically the cerebellum would fill this whole space here. And you can tell it's thinned out with degeneration in certain areas, and that degeneration from chronic alcohol use or chronic alcoholism can lead to a permanent ataxic gait, is one of the most common features, or a permanent staggering gait. And it can also lead to memory loss and impaired motor learning. And so we talked about these non-motor functions of the cerebellum really early in the lecture, and I said we're not going to talk about those too much, but it will relate to when we talk about disorders of the cerebellum. So one of the things that we can see is when there's actual damage or degeneration to the cerebellum itself, we can have memory loss, or the inability to form new memories or new motor memories. So we can see both problems with motor learning and learning sort of any new task. And alcohol can also have effects on the developing brain. So you guys have probably heard of fetal alcohol syndrome. I believe the most PC term now is fetal alcohol spectrum disorders, relating to the fact that the effects of alcohol on the developing brain can manifest in a variety of ways. And usually the severity and the type of dysfunction that you see is based on how much alcohol was consumed during pregnancy and when it was consumed. So the timing of exposure can be important as well. One of the things that we see in FAS is hypoplasia or underdevelopment. Hypoplasia means underdevelopment of the anterior vermis. So that anterior part of the vermis, that central piece. So a much smaller cerebellum or decreased volume than we would expect to see, and that death or degeneration can occur in two cell layers, the Purkinje cell layers. And what do the Purkinje cells do? They're the major what of the cerebellum? Output of the cerebellum. Also in the granule cell layer, which we didn't talk about, but it's sort of that first layer where all of the sensory motor signals synapse, and where a lot of that integration occurs. So I don't know where I got this picture from. I think it was on a previous slide. This is a really small cerebellum. I don't know that that is truly the level of degeneration that you would expect to see in fetal alcohol syndrome, but it would be an example of a very severe hypoplasia. So in kids with FAS, some of the types of problems that we see, it can impact motor coordination, as we would expect, visual spatial processing, learning, and memory, which were all sort of those non-motor functions of the cerebellum that we didn't really talk about the pathways for today. So again, impacting motor coordination, visual spatial processing, learning, and memory. Yeah, Tara.
What goes up the rest of that space? Or do they just have smaller hands? Or do they have increased?
There are some cranial malformations in FAS. I don't know if it's particularly because of the cerebellar loss, because you can also get loss in other areas of the cortex as well. And you guys always ask me these like anatomical surgical questions. I'm not sure what fills this space, or if it gets filled. I don't think, in FAS at least, I don't think you're getting a lot of, especially from the cerebrum, is not going to project, because you've got a layer of dura there, the tentorium cerebelli, who remembers from week 1? I think that's what it's called, that forms a tent or a roof between the cerebellum and the cerebral cortex there. So I don't think you're going to get you're not going to get cerebral neurons taking over space of the cerebellar space. Yeah. And again, what FAS looks like, it can look really different in different kids because of the amount and the timing of the exposure. So again, just to bring it all back together, cerebellum is going to be important for timing, accuracy, sequencing, and coordination of movement. It smooths out our movements and allows our joints to move synergistically. It provides a backdrop of postural stability that we can move on, and it facilitates our ability to learn new motor tasks. If we have damage to the cerebellum, then any or all of these can be affected. And often the term that we use is ataxia when we have problems in multiple domains, but we can also measure and identify the symptoms separately. My recommendations for studying is to make sure, you guys did great on your basal ganglia quiz, by the way. I will try and get those back to you right after class. But at this point, make sure that you can distinguish the functions of the basal ganglia and the cerebellum. So what are they each responsible for? What are their key functions? How are their inputs and their outputs the same and or different? We talked about like basal ganglia doesn't get input from the spinal cord, but the cerebellum does. So what are those similarities and differences between the two? How are lesions or damage to the two different? We talked about today basal ganglia, you have resting, tremor. Cerebellum, you have an intention or a tremor during voluntary movement. What are other similarities and differences? So think about the quality of the movement. They both contribute to quality of movement, but how does that manifest differently if you have a cerebellar disorder versus a basal ganglia disorder? So those are my questions to you to ponder as you try and pull all of this together. We are officially done motor. Next week, we're going to review cerebral blood supply, right? Because you guys did a little bit of that in anatomy already. So we'll do cerebral blood supply. We're going to do lesions. So we're going to talk about stroke. We talked about it a little bit, but we'll talk about it more in an integrative way. If you have damage to this artery or damage to this region, what do you expect to see? Or vice versa. A client presents with this. Where do you think the damage is? What artery do you think first? And then the last couple lectures are topics of interest. We're going to talk about learning and memory, and we'll talk about behavioral stress regulation, stress systems, and all of that. So we'll get a little bit away from sensory and motor for these last couple weeks. Questions? All right, put on your smiley faces. You've got a hard professor next.
Could you